Good afternoon. Welcome, and thank you for joining us for today's session, Frequently Asked Questions about Multiple Myeloma Precursor Conditions. I'm Quinn Young, Chief Mission Officer at the Multiple Myeloma Research Foundation, and I'm joined by Dr. Ben Diamond, Ms. Stephanie Mompoint, both from the University of Miami in Florida, as well as smoldering patient Elizabeth Pina, a myeloma patient also living in Florida. They've agreed to come on and join us to answer some common questions that patients and their caregivers have about myeloma precursor conditions, which are frequently MGUS and smoldering multiple myeloma. So let's get started. Dr. Diamond, we'll start with you. Tell us how most patients find out that they have MGUS or smoldering. What are the symptoms that cause them to be diagnosed with the disease, or at least come to the doctor with some questions?
Yeah, first of all, thanks so much for having us on today. It's really nice to be able to address a lot of these questions that we get a lot in clinic and that I think just a lot of people have in general. So to answer this one, man, all roads lead to MGUS is what a lot of us like to say. And that's because when you're in a specialty clinic with some strange symptom, oftentimes, a nephrologist will see something on the labs, or a neurologist will detect maybe that you have a neuropathy, or the rheumatologist is considering some inflammatory condition. And everyone will end up sending a serum protein electrophoresis, which is just a common lab test. And very commonly, just because MGUS is a very, very common condition, we will pick up an abnormal protein. And it's that kind of broad diagnostic journey that will usually lead people to find that they have something like this, and then be referred to a hematologist to get a little bit more information. Sometimes even if you're just going to a primary care doctor and they're very astute and they realize that you have a little bit of extra protein on routine testing, they can send one of these SPEPs, find a small amount of protein, and then send you in. Turns out to be a little bit less common than the subspecialty route, but in general, most people will be tested for some other condition. Incidentally, we'll find some protein like this, and only very, very, very rarely will the protein that they find actually be causing any symptoms at all, because generally, by definition, this condition is not a disease. It is asymptomatic. It just happens to be there, and it may be of very little clinical consequence in most cases.
And how about smoldering myeloma? How does that differ in terms of presentations of symptoms from MGUS or from active myeloma?
Also, great question. So for us, kind of in the myeloma field, there's less and less evidence that MGUS and smoldering are any different than each other. They're kind of just an arbitrary breakpoint where we say, okay, when the protein gets high enough, when the number of plasma cells in the bone marrow get to an arbitrary threshold, we change the name from MGUS to smoldering myeloma. And that's because historically it's been seen that when you have a little bit more protein, when you have more plasma cells in the bone marrow, there's a higher risk that eventually this could turn into multiple myeloma. At the end of the day, at the cellular level, at the DNA level, these conditions are probably very similar, if not the same thing. They're just being caught at a different point in time. And so by definition, again, smoldering multiple myeloma is not symptomatic. It shouldn't be causing any problems at all.
And Stephanie, when you have a patient who's either MGUS or smoldering, how do the conversations differ, again, depending on whether they have MGUS, smoldering, or even multiple myeloma?
Hi, Anne. Thank you for having us here again today. To answer your question, the conversation really is going to be around the lab values, right? If your M protein is less than 3, like Dr. Diamond say, then you fall under the bracket of MGUS. And if it's a little bit above than the 3, then it's considered smoldering multiple myeloma. Now, in addition to that, the bone marrow biopsy, the amount of plasma cells that is captured on your bone marrow, if it's 10% or less, that's MGUS. And if it's between 10 and 60%, that's considered smoldering. Now, both of these conditions, they are asymptomatic, but if you have a patient that comes in and the patient's saying, well, I recently had a fracture without any injury, any trauma, or I've been found to have anemia, or I was recently hospitalized and they told me that my kidney function was out of whack, then at that point, we would identify the CRAB criteria and this patient will fall under the category of multiple myeloma.
And what you bring up bone marrow biopsy, what will prompt, moving from the SPEP, the blood work, to a bone marrow biopsy, what leads to that step?
So with smoldering, again, once the blood work leads toward the smoldering condition, a bone marrow biopsy and a PET CT is indicated, because at that point you want to have a clear picture of where we're starting and exactly where we are. That way you could have a clear determination if it's indeed smoldering or if the number of plasma cells in your bone marrow is multiple myeloma.
And Elizabeth, we're so happy to have a real life smoldering patient with us and we know your doctor is Dr. Diamond. Tell us a little bit how you were diagnosed. Is what you're hearing from the two of them consistent with your story?
I was, every year, I was, I'm that type of person that goes for a physical exam every year. Okay. Consequently, I retired in June of 2021. And then I went for my physical, and I wanted to do the physical because my insurance was going to run out in August, and I said I better do this before. So I went in, like Dr. Diamond had mentioned. I went in, and I had a blood test done and all that, and then the doctor called me and said, "Can you come in?" And I thought it was just whatever. So I went in, and she said to me, your anemia, it's bothersome. I said, "What anemia?" She says, "Well, I've been following it up for 6 months. I did two exams within the year, 6 and 6. And I see that I didn't like it. I don't like it. I want you to go to an oncologist." The word oncologist for me is to run away, right? I was in fear. I said, "What do you mean oncologist?" Because my brother had a stage 4 cancer. So she says, "I want you to see so-and-so." And I said, "Okay." And I'm the type of person that I wanted to get rid of the thing right away and find out what it is. So she sent me to somebody in Cleveland Clinic, and he started doing the exams. He did a bone marrow. He did a PET scan. He did blood tests galore, MRIs, CT scans, you name it. And then one day he on the phone, which is one of my called me and said, "You have myeloma." I said, "What? Myeloma?" Computer. I looked at the computer and I saw that, and I was devastated. Psychologically, I thought my life is over. I might have like 6 months to live or something. And at that point, I did not like the idea that somebody will call you on the phone to tell you those news. But anyway, I went with him, and, he asked me to come in. And at that point in time, I said, "Listen, with all due respect, I want a second opinion. And I'm going to Sylvester Cancer Center because my brother's life was saved by Sylvester." So have a great day. I picked up all my exams, and I brought it to Sylvester. They gave me, to be honest with you, I told you at the beginning, I am very fortunate. I am, what can I ask? Dr. Diamond came to me especially because I was devastated. By that point in time, psychologically, I didn't even know. My family, except for my mom doesn't know this information. But my family was devastated. They thought, "Well, this is it." "But you just retired." I said, "Yes." So that's everything that went in. I was, again, when I saw him and he was brought in to do research, whatever research you want to do on me, I'm fine. Because if you want to, what my thoughts are this: it's not me, I already have it. But if you can prevent someone, or the prevention can be found previously, I don't know, before, I don't know, whatever I can do to help, I'm there. That's how I feel.
Maybe I can jump off of that, Ms. Pina.
Sure.
So I'll say when you first came in to see us, I remember how worried you were, and we decided at that time that we had to make sure that the diagnosis was clear. Right? And that
Exactly.
was
Yes.
the second opinion. And if you don't mind me sharing, when we did your biopsy once again, we saw that
Yes.
there were 40% plasma cells in the bone marrow,
Yes.
and you were not anemic. You had no other signs that there was anything going on, just solely that there was a number of cells, abnormal cells in the bone marrow without symptoms. And because of that, we were able to sort of downstage you and kind of slow that alarm process down and say this wasn't cancer, it wasn't causing problems, this was a precursor condition that you had smoldering multiple myeloma.
Correct. Correct.
And I just have to commend you for doing pretty much everything we encourage patients to do, to seek a second opinion. Even if you're seen at a world-class center, go seek out something else, because there's still a lot of questions about this disease, and there's so many amazing centers to find the right doctor and team for you. I really commend you, and the fact that you're willing to raise your hand for research so that others can learn from your diagnosis is just tremendous.
I mean, it's I'm empathetic. I mean, I feel like, people might feel the same way I felt at that point in time. Especially, when you have worked all your life and you come to a point when you're saying, oh, okay, now I can have some fun. I don't have to go to work. I'm retired, so on and so forth. And you find out this out? No. So if anything can be learned, I'm willing to share. Mm-hmm.
Well, one question that, as we were talking before the live stream started, Elizabeth, you said, and we hear this all the time from patients, what determines the risk of a patient progressing? And so, Dr. Diamond, if you can help patients understand if they've been diagnosed with an MGUS or smoldering, and certainly the vast majority of patients with MGUS never go on to even develop smoldering multiple myeloma. What are some of the risks? What are some of the signs that a progression may be happening, and whether a patient may be at high risk for progression?
Sure. I think this is probably the meat of it and the most important thing. And for that reason, I may end up talking just a little bit long on this particular topic. So I'll try and space things out, because these are the questions that I think most people want the answers to. So the first step in the journey is trying to figure out what we call this thing, whether we call it MGUS or whether we call it smoldering. Because usually at the beginning, if you're coming in with just a blood test and you see that there's just some protein there on the blood test, all we can really call it is that you have what's called a monoclonal gammopathy. In other words, you have a protein that's clonal. It shouldn't be there, but we really don't know what the risk is. We don't know what's going on inside the bone marrow, et cetera, et cetera. So when we define something as MGUS, by definition, you've got to have less than 10% of these abnormal cells in the bone marrow. And at this point, you can start to risk stratify. MGUS, you should know, is extremely, extremely common. By the age of 70, potentially 1 in 10 to 1 in 12 people in the United States has it. All right, and so it's extremely common. You're in good company. I mean, if you go up onto the street, it's basically 1 in 10 people have it. And so the risk of progression in general among the entire population is extremely low. It's about 1%. That being said, what we want to do is try to understand a person's individual risk. So the best we can do at this point in time with the tools that we have is to measure the amount of protein that there is. And so we say that generally speaking, if you've got MGUS, again, less than 10% of these plasma cells in the bone marrow, if your protein is greater than 1.5, if you have an atypical kind of protein, so generally the most common is an IgG. If you have an IgA or an M, it's considered a little bit higher risk. And then we also look at the light chains, which are kind of a little piece of the protein that can fall apart, float around in the blood, and be calculated separately. If you have an elevated ratio of the bad one to the sort of normal one, we consider that to be a high risk feature. That being said, these numbers are based on retrospective cohorts, right? They're not based on you in the moment. They're based on history. And so all we can really do with these numbers is to help calculate a relative risk. What happened to people like me? It's not an individualized risk. And for that, we'll talk about where the research in the future is headed. Then for the smoldering, so this is at the point where you've done the bone marrow. You see that you've got greater than 10% plasma cells in the bone marrow, but you don't have multiple myeloma yet. Here, the risk factors change just a little bit. because by definition, there's more of this stuff in the bone marrow. So at this point, the most commonly used stratification is that, we look at the number of plasma cells in the bone marrow. If you've got greater than 20%, it's considered a risk feature. If you have basically greater than 2 grams of this abnormal protein floating around in the blood, it's a risk factor. And if the light chain ratio, we talked about those little things that float around in the blood, if that's greater than 20, that's also considered a risk factor. And to give you some sort of relative numbers that can help, if you have all of those risk factors together, there's basically, let's see, get the exact spit out here. It's a 29-month median time to progression for people that do progress. So looking at around 3 years. So if you have all of those 3 risk features together, we do consider that something that's considered high risk. And it's really good to have a hematologist on board or a myeloma specialist on board, because there may be something that we can do about it. If you've got none of those risk factors, the time to progression is very, very low. And generally speaking, we just monitor. The last part of the question you asked was, are there any signs that I can tell, once I have one of these things, what might happen in the future? Will I progress? What are the signs that I might be progressing? And there's no easy answer to this, but that's why we watch over time, because the general sense is that if the numbers are starting to rise faster than we like to see over a short period of time, we consider that there's probably an imminent progression starting to happen. And for that reason, it's nice to have a myeloma specialist on board, because you really want somebody who understands those numbers to be able to help you interpret them and to see if that rate of rise is enough to worry us into doing something.
So as much as you said you'll slow down, I do want to go back to monitoring, because this is a very, very frequent question. How can you walk everyone through, if you're an MGUS patient, from diagnosis moving forward, how often you should be monitored and with what tests? And then the same with smoldering.
Sure. So if you know that you have MGUS, or if you have just a small amount of these proteins in your blood, generally speaking, once a person is diagnosed, and again, this can vary from patient to patient, but generally speaking, I'll check another value, a set of blood work, in about 6 months, just to make sure we're not missing something. And if that's stable, then I spaced it out to about a year. All right, so once a year, you're getting followed for the MGUS. If you've got smoldering, because the risk is a little bit higher, you're anywhere between 3 and 6 months that we're following up that blood work. And again, the blood work here is just looking at the protein levels. The specific tests are like an electrophoresis, the free light chains, and also an immunofixation, which is to be more specific about what protein we're monitoring. And we'll look at a couple of other things as well.
So, Stephanie, for patients who are diagnosed with smoldering or MGUS, and there may be some differences, what else do you typically tell patients in terms of if there are any other lifestyle modifications they should be doing, knowing that they have these diagnoses, in addition to being regularly monitored?
I actually get that question quite a bit, because patient wants to know, like Elizabeth was saying, once you hear the word cancer, you're wondering, what else can I do, how I can help myself? My answer to that is usually an overall healthy lifestyle will help in the long run. Make sure you have a healthy eating habits and also an active lifestyle, because with obesity comes other comorbidities that will put you at risk for different conditions. So overall, you want to try to stay healthy as much as possible.
And Elizabeth, did you make any lifestyle changes with your diagnosis, and or is there any advice that you would give to patients in terms of pursuing those healthy choices that Stephanie described?
Well, personally, healthy wise, I do a lot of walking. I try to now, because I have the time, I can, go out and walk around town. I mean, I walk all the time. So if I can, even with the heat going on and everything, early in the morning, I just walk. I lost, at the beginning of all this, about 25 pounds. I have kept some off. Okay. I try to also look at the sugar level. Okay. I'm not telling you I'm perfect, because I'm not. I love sweets, but I tried, to look at those numbers, especially the sugar, because I know sugar could be a factor. The other thing is I have a therapist. I see someone now. I'm seeing him every 2 weeks, and basically it's just I need to speak to somebody. I need to share things and because I can go into depression really easy, and I don't want to do that. I have my responsibility, major responsibility is to my mom, which is 96 years old. So that 96-year-old keeps me very busy. She's very, very active. So, those are the things that I try to do. I'm not telling you I'm perfect. I love to eat. I eat very well. Um, I'm not going at this stage in my life. I'm not going to say I'm going to go on a diet because, but I do a lot of fluids, no sodas, nothing like that. And I try to travel a lot. I go out a lot, and that helps out psychologically because when you are, seeing new things and experiencing new places, believe me or not, you're living. You're living. It's life. So, we try to do 2 or 3 trips a year. And I'm also working part-time to keep my, keep me in the loop with people, socializing, and it helps. Especially with depression and also with socialization. I'm 70 years old. I like to socialize. So I would say that you have to keep living.
Yeah.
It's basically, you have that thing in the back of your mind that you're not perfect. Your health is not completely there, and you pray every 3 months that everything's going to be okay.
No, thank you for sharing that. You're again describing what every patient should really take care of: their physical health, their mental health, enjoy life, but stay on top of your diagnosis and
Correct.
monitoring. I did want to take a question from the chat that someone asked about bone marrow biopsies and looking at cytogenetics for MGUS, when and if that's done.
Okay,
Dr. Sure.
Yeah, I'll go ahead and take that one. So generally speaking, not everybody needs to have a bone marrow biopsy at the beginning. There's a few different stages at which we try to risk stratify. I mean, you can't believe the number of people that come in with extremely low M spikes, 0.2, 0.3, basically normal free light chain ratios, and nothing else going on in their blood work. And again, we said how common this condition can be. And so if you have extremely low values, there actually is a recent tool that came out. You may be familiar with the folks over in Iceland. They're doing a study called the iStop study. Really, really cool study. They're screening the entire population of Iceland for these monoclonal gammopathies and trying to understand how they evolve and who of these people are going to actually end up and develop multiple myeloma. So the study is obviously going to take a very, very long time. But some of the initial stuff that they've been able to find are basically they try to come up with a calculator that determines the likelihood of somebody having greater than 10% bone marrow plasma cells. Because that's generally what we're trying to find. If you've got greater than 10% bone marrow plasma cells, you're at the smoldering stage, there's a higher risk. We want to track you a little bit closely. So there's a calculator that basically looks at the amount of protein that you have, whether any of the other immune globulins, your general immune health is affected, the kind of elevation of these proteins themselves. And if everything is extremely low, the likelihood that you actually need to go for a bone marrow biopsy is similarly low. So that calculator is available. We do use it. But generally speaking, if the numbers are low, we don't always need to do a bone marrow biopsy. Secondly, if we are seeing that there's some numbers that are high enough for us to get concerned, that we want to look a little bit deeper, that we want to make sure we're not missing anything, we will go ahead and do that bone marrow biopsy at the beginning. We'll often pair that with whole body scanning because having the bone marrow by itself in absence of a whole body scan doesn't really give us the full picture. And at that point, we're hoping that, in that bone marrow biopsy, we'll be able to quantify the number of cells and also secondarily to do those cytogenetics, to do the FISH, to try to understand the genetics of the disease as best we can, because we want to see if there are any high risk lesions that might help us understand that person's risk.
And just a couple of other questions from the chat before we shift topics a little bit. One person asked if amyloidosis patients also start out with MGUS.
Also a really, really good question. Amyloidosis is sort of a broad diagnosis. I think for the purposes of our conversation here, we'll talk about the myeloma-related amyloidosis. And in this case, yes, it's the same kind of thing. Generally speaking, and this is kind of trying to demystify it a little bit and just speak in generalities here, but in multiple myeloma, the problem is the number of cells, right? It's these cells that are causing the issue in your body. You have a bunch of them. They're invading, they're knocking out your normal cells. They're causing infections by pushing out your normal immune system. That's myeloma. In amyloid, the problem is not the cells, it's the protein that the cells are making. So the protein is the bad actor. You don't really need to have a lot of the cells to have problems with the amyloidosis. And so for that reason, the two often start at the same place because the commonality is that we are looking at the protein. It's just that the presentation and the pathology is related to two different kind of arms of the same process.
And then one last question about levels. A couple of questions coming in about at what level with the light chain ratio should you be concerned about, and also M spike?
Yeah, I think looking at individual values can be rough. Looking at light chain ratios can be rough, as I'm sure a lot of you are aware. For example, very, very small changes in the light chains can lead to very big changes in the ratio. And so I know that there's a lot of concern related to that when people look at their labs on a day-to-day basis. Generally speaking, for me, if I'm seeing somebody in clinic and I'm trying to decide whether I should be concerned enough to do a bone marrow biopsy, if I see that the M protein is greater than 1 or so, the light chain ratio is up in the 8 to 10 range or higher. These are things that kind of flag to me that I should probably look a little bit deeper and make sure we're not missing a smoldering diagnosis or something worse.
And then slightly different topic, Stephanie, one of the questions that we often also get from patients who are diagnosed with either an MGUS or smoldering is, should my family members be screened? Should they, is there anything that they should be doing to be alert for a potential diagnosis?
Sorry. We're talking about MGUS and multiple myeloma. What I found out is that this cancer is relatively rare. It's not like everybody that has MGUS will definitely have multiple myeloma. Now, there are some factors that were identified, like if you have a first-degree family member, like if you have a sister, you have a mother or aunt, well, a brother, I mean, that was diagnosed with multiple myeloma or any type of plasma cell disorders, then your risk for developing multiple myeloma is slightly higher than the general population. And another thing is African Americans or Black, they have a higher risk of multiple myeloma also. Now, if I have a patient or if I'm talking to somebody who's a male and he's 40s and they're telling me that, hey, my mother had multiple myeloma, do you think I should be screened? And my answer to them will be definitely, because you have two identified, actually in that case, 3 risk factors that put you at a greater risk of developing multiple myeloma.
And so to build on that a little bit, because a lot of patients say, okay, I'm willing to be screened. Who should I talk to? Who in my healthcare team should I talk to, and what test should I request?
That's a good question. Usually the MGUS is found on incidental finding. So if you have any questions like that, the primary care provider would initiate the conversation and the testings that are needed. And if anything comes back abnormal, then they will refer you to hematologists for further testing. And also one of my patients, we spoke about, there's a study out there, the PROMISE study, because there's 2 people in her family that have multiple myeloma. And we talked about the PROMISE study where they're collecting data on people that have first-degree relative with multiple myeloma or any type of plasma cell disorders. And it's free. It's open to the public. It's free. That's another way you could get screened.
Got it. And I do want to go back to something that we were talking about before we went live. Elizabeth, you mentioned, and you may even want to show your binder, how you're tracking your visits and your test results. And perhaps not every patient needs to go to the same level of detail.
No,
but tell us what you do and how you would guide patients to stay on top of their test results.
Well, it's my way of, I mean, this is my personality. Okay. So when I found, I can tell you, looking at my binder right here, I started collecting information since day one. And I have tabs of the exams, the bone marrows, the PET scans, everything is all organized. So the last test that I did 3 months ago, as you can see, look at the paperwork. This is all the paperwork. So I start looking. The good thing is that the service of is very good. So what I do is I track my CBCs, I track them down, see how they are, all the little areas, and I see from the beginning the trends. And if I see something, I circle it, all right? And I plan. That's my plan. I'm going in to see him. So my plan is to ask, okay, what does this mean? And usually Dr. Diamond is ready for me. And then the biggest, always. And one of my biggest concerns, to be honest with you, is I look on a monoclonal spike. Mm-hmm. That freaks me out. If it stays in 40, I know that he's going to tell me, okay, don't worry, everything's. I also look at my kidneys, because I'm afraid that if something might happen with my kidneys. So these 3 months, like I'm going to go for a blood test next Tuesday. When I get there and I get my blood test done, my phone is already ready to receive the information. And you can see, and it happens, I'm sure that it happens to everybody, where you open up and you're praying to the Lord that nothing has changed that much. Okay. But some people don't even bother, I'm sure. I also have a endocrinologist that he's very, very good. So he follows 2 certain things. I look at the difference, between how I feel. Like, for example, I discussed this previously with Dr. Diamond. I usually feel very tired, I didn't used to feel the tired, but I'm tired most of the time. But I figure, well, it might be, my disease. So I try to control that psychologically. I said, no. And like I was fixing my closet right now before I join in. But, I am not like everybody else, I just had a bone density exam, right? And it was okay. My fear is to get to the point where I get these lesions in my bones. And I know that is critical. Okay. I already had a hip replacement because I fell, and that was after I found out. So, those little things are the ones that I follow. Now, I don't know, everybody is different. Some people will come in and ignore the whole thing. But for me personally, this is my health. This is my life. So I like to be aware of everything. And I expect, my team and Dr. Diamond and his people to tell me whatever it is. I'm ready. And if I need further exams or I need anything else, please ask me and I will do them. I have no, this is my life. And I think everybody should take this as a serious thing. I don't want it to get to multiple myeloma. No. So I know that at this point in time, there's nothing you can do. You just have to wait. I'm in my 3rd year now. So my other idea, in my mind, I'm thinking, let's see if I can get to 5 years, so every year I'm counting down. We'll see. I just, I'm in the hands of the Lord, and I'm in the hands of Dr. Diamond. I trust him tremendously, and he knows this. So, I'm in good hands.
You are. And one thing, particularly for the people listening, to emphasize that was brought up earlier, is not to fixate on a single result, because it's a whole picture that puts a diagnosis together. And while there are specific values for MGUS or smoldering, it's not as clear cut. So it's really important to look at the whole picture with your doctor. And if you're concerned about a specific number, to ask your team about it. But if you're seen by a specialist and they really say, no, here's why it sounds like you're here, but you're really in this category, that's okay. Because not everything is quite as hard and fast as it may seem.
Yeah. It's good that you said that, Anne, because one thing I want to add to this is that while you're looking at one number, you're looking at one lab result, one thing that it's okay to ask us, your team taking care of you, because sometimes if a different lab is used, then the unit is different, and then you're going crazy because the numbers look better. How did I go from 3 to 30? That's because the unit is different, and that's why we're here to make sure that you understand your labs and we're interpreting them the right way.
That's really true. I found out from at the beginning, from one lab to the other, I noticed the different areas that they were not the same. So I did a little research. I thought, oh, this is it. It's not everybody doesn't have the same. So yeah, I agree 100% with that. And also, let me add, I understand learning with Dr. Diamond that not only one exam. I know it's a whole entire exams that they go into this. So I understand that perfectly. But sometimes you kind of say, let me see what my monoclonal spike is right now. Because in your mind, you say the higher it goes, the worse it's going to be. But that's a personal thing, that you should discuss with your physician, because that's what they're there for.
And so finally, I think a lot of this really emphasizes the fact that, if you are worried, if you're starting to look at your lab values and you're the kind of person that looks at a value and starts to lose sleep over it, I think that's the time where you try and find a specialist. And that's because somebody can really help you make, heads or tails of what you're looking at, to tell you whether you really should worry or to tell you whether you shouldn't, because we'll look at everything in totality to determine if the lab value is actually concerning or not. It'll just give you the peace of mind rather than perseverating on an individual value. If something comes back, it turns from black to red, even if it's just outside the reference range, et cetera, et cetera. These are the things that you want somebody on call to be able to discuss those things with.
So before we move on to a few questions around treatment, there was Elizabeth, you made a comment about seeing your endocrinologist. And Dr. Diamond, you said at the beginning how there's often referrals from nephrologists, neurologists. How does an endocrinologist play into a diagnosis, and is there any relationship to Hashimoto's?
So a really nice question. It previously was thought that people with autoimmune diseases might have a higher risk of having MGUS. The iStop-MM study has been really nice because they've done everything at the population level, very regimented. And it seems that previous relationship where people had an autoimmune disease and they were more likely to have it was all a referral bias. And that was just because those people that were having autoimmune diseases were likely to be older, likely had comorbidities, and as a result, just ended up having this condition diagnosed at a higher rate, right? So there's not actually a link between the two, as far as we can tell, at least, looking at the Icelandic population, which we have to extrapolate and say is representative of the rest of the world.
So another big set of questions we get is around treatment, particularly obviously for smoldering multiple myeloma. But Dr. Diamond, can you tell everyone a little bit about when treatment may be indicated? There's a lot of questions coming through in the chat too, or particularly the use of Revlimid in smoldering patients.
Yeah, I think this is a big key point. A lot of people are trying to answer this question. To take it back a step and to talk about the Revlimid, I guess the first thing I'll tell before maybe it gets lost in the message or somewhere is that if somebody recommends treatment for your smoldering multiple myeloma, make sure you at least get a second opinion, because what is about to happen is that at a point where you may or may not be asymptomatic, we are now asking that person to become a patient, right? They're going to start treatment, and that treatment may be indefinite. And so before you embark on a journey like that, you want to be sure that it's the right decision. So first of all, again, if someone recommends to you that you should be treated for your smoldering multiple myeloma, make sure that's the right course of action. So taking it back a few years, there were a couple of large randomized studies that looked at whether or not you could give lenalidomide or Revlimid in combination or without dexamethasone. One study in Spain, one study here, pretty large. Basically finding that not that there was a likelihood that we could stop multiple myeloma, just that we could delay the appearance of multiple myeloma or delay the progression to multiple myeloma by giving therapy up front, okay? And that sort of makes sense, right? If I'm going to give anti-myeloma therapy to an asymptomatic person, probably the multiple myeloma is not going to develop for a bit of a longer period of time. Now, that therapy, Revlimid, is actually approved. It can be given for patients with smoldering multiple myeloma. I caution against it just because those studies were done in a time where the definitions for smoldering and multiple myeloma were a little bit different, and those cohorts of people that were treated on those studies are actually different than the smoldering patients of today. And that being said, these days, we have better therapies for multiple myeloma. And so a lot of people will advocate that it makes much more sense to just wait, because by the time the multiple myeloma develops, we'll have good stuff to treat it with. And right now, what people are trying to do instead of delay the progression is to try to understand if, for people with particularly high risk, we can give a right kind of therapy that actually might eradicate the condition sooner, potentially at a time where the disease is less evolved, at a time where there's less end organ damage, where people are healthier. And that's the question I think a lot of people are trying to answer right now. So short answer, Revlimid, single agent for smoldering multiple myeloma, generally will recommend against in almost all cases. I actually don't think I've ever treated anybody with it. But if you've got high-risk smoldering multiple myeloma, I think it really is worth considering a clinical trial with the intent of trying to eradicate that condition. And that's kind of on an individual basis. People that are more worried about it in consultation can do something like that on a trial. People that would rather do observation, I think, would also be well-suited to do that.
And we know, too, the definition of high-risk smoldering multiple myeloma is also shifting. But for now, can you help everyone understand, for a patient, if a patient hasn't been told, what they should look for to know if they may be high risk or not?
Sure. It kind of takes us back to the 22-20 criteria. I think that's basically the accepted risk criteria here in the States. So just one more time, if you've got more than 20% plasma cells in the bone marrow, an M spike greater than 2, or a free light chain ratio greater than 20, it's considered to be high risk. Adding on top of that, sometimes we add FISH. If there's a 414 translocation, a deletion 17p, or a gain of 1q, there's a little bit less evidence for these things in the smoldering state, but most people will generally agree that those things make it high risk. And then finally, if you've got evolving markers, if these numbers are changing over time, we consider that also to be high risk. And most of these features would qualify somebody to be at least on a clinical trial for the versus at least very close observation.
And Stephanie, another question that's come through is the use of herbs and supplements. What do you counsel patients who ask about that, whether they're on therapy or not?
There's still a lot of research being done about herbs. There's not, I've looked into it. There's not one study that is conclusive to say that herbs or any leaves or anything can eradicate the disease or could be served in lieu of therapy for multiple myeloma. If we have a patient on treatment, we caution against using certain herbs, especially because they might be interacting with the medications that they're on, or they could cause toxicities like liver toxicities, nephrotoxicities. So we caution against that.
And going back, Dr. Diamond, you mentioned clinical trials. Are there some ongoing clinical trials for patients to consider, either with the MGUS is more likely to be a registry, like you mentioned, iStop-MM. But what are some trials that you find could answer some key questions about delaying progression, either for MGUS or smoldering?
Yeah, so a little bit of the challenge right now is that most of the trials looking at treatment for smoldering multiple myeloma are single-arm studies. And so we'll never be able to fully answer the question about whether that treatment is better than observation alone, which is basically the current standard of care. Many institutions have studies that are looking at the treatment of smoldering multiple myeloma. For example, we have one here at the University of Miami. It's called the REVIVE study. And for people with high-risk smoldering multiple myeloma, they're getting combination of teclistamab, which is a bispecific antibody targeted against BCMA on the surface of the plasma cells, and also in combination with Arcellx or daratumumab, a CD30 antibody. So we have that trial ongoing. Many centers are doing similar studies using the bispecific antibodies. And as I mentioned earlier, these agents are now being used with the intent of trying to eradicate the smoldering disease because the treatments are getting better and less toxic. And so that's why people are asking questions like these. For things like MGUS, lots of registry studies. As Stephanie mentioned, there's the PROMISE study. It's done by Irene Gobriel and Dana Farber. You can send in your kits. It makes it very easy. We have our own study called the TRANSFORM study. Actually, Ms. Pina is on that study, where we're getting bone marrow biopsies and images on a yearly basis. We have, I would say, expertise in genomics. I do genomics. We have Francesca Moro, who does genomics. We have a lab that does this kind of stuff. In general, because this can get really heavy, I'll just say that these conditions, MGUS, smoldering, they're sort of arbitrary definitions. What really is going to be at play over the next few years is that you're either going to have multiple myeloma at an early stage or you don't. And a lot of the whole genome sequencing that we can do on the TRANSFORM study and just in general are able to identify genomic risk factors that we can't pick up with the usual laboratory tests that will help to personalize people's sort of definition of risk to really understand whether what they have is what's going to become multiple myeloma in a couple of years, or whether we can just not worry about it at all because it's indolent and not likely to cause any problems.
And a question, Elizabeth, for you. You obviously track your test results very closely. What do you do to stay educated should your disease move forward and progress to multiple myeloma? What do you do to kind of stay on top of what treatments might look like?
I have looked at different things. I was reading something about this transplant, and I don't know because this is more a doctor, situation. I mean, this is me, a layman. But I was reading something where they can take some of those cells, right, and then it's like cleaning the cells and putting them back into your system. And at one point I said to myself, whoa, that sounds pretty interesting. I did not discuss it with Dr. Diamond. I just read it. Sometimes I read, sometimes things come in. By the way, I'm on signups to different information sites. So sometimes they send things and I read them, to try to keep abreast. But that particular thing really caught my attention because I said that could be something interesting where they could take maybe your cell, your blood, whatever it is, and then do like a type of transfusion back into you. And wow, I was like excited. I did not discuss it with him because I thought at that point in time, I'm not at that point where I am going to be asked to be a patient taking medication. So, and he's probably thinking, oh, Liz. But yes, I try to read as much as I can. Sometimes it's things that are sent to me. I try to stay away from Google a little bit because Google could be detrimental, they don't give you the right information. But yes, I keep abreast.
Well, and actually, a few questions have come in about, and I'll let Dr. Diamond and Stephanie too explain the process of high-dose chemotherapy and stem cell transplant, but also CAR T-cell therapy. So some questions have come in about should patients be banking stem cells? And there was a question in the chat, should they, have their T cells modified for CAR T? So, I'll let the two of you address some of those questions, but it's really, forward-thinking patients.
Yeah, so I'll try and address them. I think it is very good to be forward-thinking. The procedure that Ms. Pina is describing is a autologous stem cell transplant, where you collect your own stem cells, you freeze them, you give high-dose chemotherapy, and you infuse them back in as a rescue. So that's a very common treatment for multiple myeloma. It doesn't really have a place in smoldering multiple myeloma at this point. There's actually been a couple studies that evaluated the use of kind of aggressive treatment plus a transplant for patients with high-risk smoldering multiple myeloma. The results haven't been as good as we'd hoped. So in general, most people will, certainly not even as a standard, it would only be on clinical trial that you would consider doing something like that. Then the question is, okay, well, if right now with my MGUS or my smoldering, I don't yet have multiple myeloma, perhaps my immune system is healthier now than it would be in a few years. And the question comes up as to whether or not we should bank our stem cells or our T cells to kind of save them for a rainy day in case we ever need them. I think in principle, it's a nice idea. But logistically speaking, the chances that you will ever need those products are very low, and the cost to bank them at academic centers or anywhere is very high. You can imagine the huge number of freezers that would be required over many years. These things are kept for 30 years in the freezers, more sometimes. The cost to keep them up and running. So right now, that's not really being done anywhere, as far as I know. And generally speaking, the immune cells, regardless of whether they're collected now or whether they're collected at the time of your first remission, when we'd be considering using one of these therapies, will be equally well suited for the most part to using CAR T cell therapy or stem cell transplant therapy.
So one other question, just going back to symptoms that's come in about whether MGUS and smoldering patients can have symptoms more typically associated with active myeloma, back pain, peripheral neuropathy. How often do you, either Stephanie or Dr. Diamond, do you see these presenting in patients presenting with these symptoms?
I'll start with that. We just have to remember that MGUS is seen on average on patients that are over 50 years old. So there are other things that could happen to somebody. If you're diabetic, you might end up with, and blood sugars are not well regulated, that might cause neuropathy. You might have chronic anemia. That could also be related to another condition. My point is, just because you're experiencing what could look like CRAB criteria, that does not necessarily mean that they're directly related to the M protein. So that's something to keep in mind. Yeah,
and I'll add to that. It's a very good point. Basically, by definition, these MGUS and smoldering are supposed to be asymptomatic, but oftentimes, just because people have lots of comorbid things going on, they'll have a neuropathy or they'll have back pain, because 90% of Americans have back pain. So a big challenge, and something that you should really speak to a specialist about, is whether the symptoms are concerning enough that we should look deeper and try to find a link. In the vast majority of cases, the MGUS, the protein, is unrelated to whatever symptoms you might be experiencing. For people that have neuropathy, more often than not, the neuropathy is idiopathic. We never actually even find a cause, but it's not related to the M protein, for example. But again, it's these kinds of presentations that usually will bring you to a specialist, because we'll have to consider them and make sure that there's nothing syndromic going on, that the protein is not related to any of the symptoms you might be experiencing.
So as we are coming up with just a few minutes left, I did want to ask a final question of Stephanie and Dr. Diamond. Elizabeth, I'm going to save yours for after. I'd love to hear from each of you what your hopes are for the next 5 to 10 years in terms of research and how a diagnosis of MGUS and smoldering myeloma could change.
Stephanie, I don't know if you want to go first.
Sure. We're doing a lot of research here at the University of Miami. And these research, they're not just for smoldering multiple myeloma and the hope of eradicating the disease or finding a cure or getting patients into deeper remission even before they get to be multiple myeloma. We're also trying to find out what, once you're diagnosed with multiple myeloma, what is the best first treatment, your induction therapy. And on the other hand, we have a couple of trials that are trying to find other therapies for relapse refractory multiple myeloma patients that had relapsed from different therapies before. So my hope is that we could get to the point where we're identifying the risks very early on, so we don't get to dealing with the reoccurrence, the relapse in the future. So.
Yeah, I agree. And I think specifically with a focus on MGUS and smoldering, what I see that's almost certainly going to happen over the next few years is that we're going to break down this arbitrary definition of MGUS and smoldering multiple myeloma. We're going to realize that everything is on the same continuum, that the definitions are a little bit arbitrary, and we'll be using things like whole genome sequencing, looking directly at the DNA of these conditions to determine what an individual person's risk is of progression. And I think the holy grail is, by the time we really understand it in the next few years, we'll be able to do that test on day one and tell somebody whether they are going to progress in the next few years or whether they can stop worrying because it's going to be an indolent condition. I think, honestly, that is a very real consideration. It's a reality that's going to happen in the next few years.
And finally, for you, Elizabeth, what are your hopes for the next 5 to 10 years?
Oh my God. Now that he said that, I wish that happened sooner, because it can determine a lot for me. I'm waiting for those 5 years. I know that I've been told that after 5 years, the possibility of this going multiple is a little bit reduced. So, that's what my light is. Every year, every July is like an anniversary for me. So, when I get to July and I said, okay, this is my 3rd year. So I got 2 more years. Hopefully, and again, there's nothing that I can do right now except maybe take care of my health. And follow up every 3 months. I mean, that's all, it's basically, how would I said it to someone? The hope is that research comes to us soon enough, that eventually that will be such a great idea that even when you are born, they can be able to determine if you're going to have some of these diseases. That will be, phenomenal. I'm 70. I don't expect to get to that point. But, for the young generation, that would be absolutely fantastic. Not many people know about multiple myeloma. Not many people know about this disease. They think more about diabetes and, the cancer, the other common things, high blood pressure, things like that heart condition. But they don't ever think about what is multiple myeloma. Imagine trying to explain that to your friends. They have no idea, So
Yeah.
hopefully, research will be there.
Yeah, and certainly we at the MMRF are very happy to one day shut our doors, put ourselves out of business because we've cured the disease. And until then, we work with phenomenal partners at Sylvester Cancer Center and many throughout the world to get to that point, because that is our goal, to have this be cured, patients completely off treatment, not even as a chronic disease. We don't want this to be an issue for patients. So we are working as urgently as possible. And it's like patients like you, Elizabeth, participating in studies as you are. It's really important because that's how we learn. And for any patient who's listening, who's interested in participating in a PROMISE or transform study, you can go to our clinical trial finder on the MMRF website. But I'd love to, we could go on for so long.
Oh, yes.
Knowing that we're up in an hour, I really want to thank all three of you for being part of this, taking time out of your day. Thanks to everyone watching. I've been going through a lot of the comments on the chat, and it's just phenomenal to see so much engagement. I did finally want to thank the partners, our pharmaceutical partners who make this possible: AbbVie, Adaptive, Baxter, BMS, Cure Magazine, Genentech, J&J, Kite, Pfizer, Regeneron, and Sanofi. Thank you so much for making this session possible. And then one final note, if anyone has any other questions, we do have 3 nurse navigators at the MMRF who will take your questions via email, web form, or phone. So please feel free to be in touch with any questions you have. Again, thanks everyone.
Thank you.
Thank you.
Our pleasure.
Thank you.
Thanks for having us.